We need to be more rigorously focused on tools and approaches that are peer-reviewed, and these things are, on best practices for self-care for healthcare providers.
Welcome back to the Faculty Factory podcast. I'm Kim Skorupski, and I'm looking at Dr. Dan Barnett, a frequent flyer now, number 2 visit. Hi, Dan. How are you?
Very well. How are you?
Good. So Dr. Barnett was here, episode number 173. You're going to want to slide back on and check that out because Dan really got us thinking about some really cool things. We talked about high dread environments. We talked about perception of risk. It equals the sum of the actual risk plus the dread or outrage. We talked about blue sky days. We talked about surge capacity threat. Super cool stuff all around emergency preparedness. Dr. Barnett is an associate professor here at the Hopkins Bloomberg School of Public Health. He's an MD, MPH. And it was a really cool talk. After we had our conversation, I said, Dan, we got to get you back because there's so many really compelling thoughts that are a little bit outside of the traditional field of faculty affairs and faculty development. And so I love the way he was kind of weaving in the workforce issues and willingness to respond and all these kind of psychological affective components of our work. And so Dr. Barnett is back here today to talk about, have another conversation around workforce preparedness, the past pandemic, future pandemics, fatigue. How do we prepare as leaders in faculty affairs and faculty development? And as faculty members, how do we prepare ourselves, our teams, our institutions, hiring people, keeping people, equipping people to do our best? So Dan, thanks again for being here. And I'm going to zip my lip and let you show us and bring the wisdom.
Well, thank you, Kim, and thanks for having me back again. I appreciate it. To your point, these are very challenging times for the healthcare workforce in many ways, but not least of which is the psychosocial aspects, as we are now at the time of this recording in our 2+ year of COVID-19. And these issues that we talked about last time and are segueing to today are really, frankly, ever more salient as it seems by the day. And by that, I mean, there are so many relevant issues regarding concerns about healthcare workforce attrition, burnout, terms like compassion fatigue, which is a real phenomenon in which it is tiring to be in a caring profession. And I'm not saying that in a cynical way. It is emotionally tiring. This is heroic work. This is the kind of work that is emotionally draining to really have this level of emotional investment in one's patients day in and day out amidst a very trying time. So all of this also ties into care for the caregivers as we look ahead to current and future challenges that face the healthcare workforce.
Yeah, Dan, you're so right, and this is so important. As we were chatting, and many institutions are, as you mentioned, there's this life cycle that we learned about in the pandemic, and now we're kind of at the just complete and utter fatigue and exhaustion, and then a little bit of. It's hard to go back to normal because you can't go back. And then there's this kind of anxiety of, well, what is the future? And all these, as you talked about, geopolitical situations happening. What's the next thing that's going to slam us in the face? How do we manage to balance the fact that we have this heart and our clinician investigators have this tremendous heart for service and science and helping, curing, treating diseases and diagnosing and prevention. And so trying to do that, serve others while also trying to build a career, which involves focusing inward on myself. So when I talk every day and coach faculty members every day, they're just in the corner up against the wall where so depleted, so, as you said, the compassion fatigue, there's almost no space, no resources, no time, no energy left to dedicate to my science. Every time I say, well, how's your science doing? There's just science, my science. Are you kidding me? Yeah, between midnight and 4 a.m., I guess, is the time that I could do my science. If I weren't a human being and needed to get a little bit of sleep and restoration.
Right.
So how do we, I hope, as you share what you do in your field, that there's going to be something you could, teach us to how do we walk that line? How do we do what our gifts and talents are put us on earth to do, to serve, but also do our science and do our research and do our papers and do our grants and build our research teams and think deeply about problems versus always going in emergency mode?
Exactly right on all points, Kim, that you just mentioned. I think that on a very concrete level, employee assistance programs have never been more important in recent memory. When we think about the role of workforce wellness, it is not just exercise and diet. It is the psychosocial. Now, those are important. Please don't get me wrong.
Right.
But when we think about workforce wellness, we need to think holistically about the toll that this pandemic and, frankly, current and emergent threats, including future pandemics. This is not the last pandemic I fear that we're going to see in our lifetimes. That the emotional toll that these events are taking on frontline health providers and academics and everyone else in the sphere of healthcare and public health. And so on a very practical level, I think one of the key issues is to, in terms of identifying lessons learned and to sort of use a phrase that we've heard, build back better, is to revisit and reinforce employee assistance programs. And that's being done in many instances. I'm not suggesting that it's not, but I think it needs to be even more universally done so that we achieve things like addressing work-life balance considerations, the issues of burnout that frontline providers have experienced, the issues of career planning and how COVID-19 and ongoing threats affect sort of the bandwidth of people to focus on their careers while they're also focusing on childcare and other family-related considerations. These are not sort of isolated considerations. We can't think in terms of one lane of family and one lane of work. They're all interlinked. Mm-hmm. And so I think one of the key insights from COVID-19 and moving forward, if there is not to use silver lining, but I'm trying to think of the most apt phrase, is it provides a sort of a natural experimental window for us to understand gaps in employee assistance and what we can do to shore up those gaps moving forward so that we can avoid, frankly, attrition or further attrition of our frontline healthcare workforce.
Dan, can you educate us a little bit about employee assistance programs? And you mentioned, it's not just diet and exercise. So I think a lot of us may, like me, right away when we say employee assistance programs, I think of at Hopkins, we've got employee discount things for going to the Baltimore Zoo, the planetarium, the aquarium, and I'm thinking of exercise, go to the gym, or these online classes that were offered us when the pandemic broke out. And I'm thinking of the farmers markets. And so that's the traditional stuff I'm thinking about. And what else am I forgetting about, daycare and care for older family members and resources that are available at the state level, the government, the big, define employee assistance programs for us. And then what are you thinking in terms of gaps and next leveling up these employee assistance programs?
Sure. Great question, as always, Kim. So by this, I mean, by employee assistance programs, I'm talking in this context, including mental health resources, for healthcare workers and other frontline responders. And when we think of employee assistance programs, historically, those allow for referral to mental health services, confidential, of course, to allow people to continue to literally function in their jobs. I think when we, in the context of COVID-19 and based on lessons learned, we need to think of it, employee assistance programs, and there are many that include what I'm about to say, but more consistently, holistically, in terms of family-related considerations, childcare, and how these all intersect. And think of these employee assistance programs as truly longitudinal in nature. It's not like a one-off session. Maybe for some people, a single session with a counselor may suffice. But the psychological trauma, and there's a lot of research that still needs to be done on this. COVID-19 at the time of this recording is still very much happening, and we are still learning a tremendous amount about it. So I don't want to speak to research that has not yet been sort of cemented. But having said that, I think it's safe to anticipate that even from COVID-19 itself, things like post-traumatic stress among providers and all of these longitudinal health impacts are accordingly going to require longitudinal work with employee assistance programs and resources for employee assistance programs to allow for a form of psychological recovery. And going back to the term build back better, we think of that often in terms of infrastructure, but we also can think of it in terms of human resources. And I think that confluence is a very important sort of synergy of ideas.
Wow, that's so important. Psychological recovery, Dan. That's so important. And I think that we're seeing evidence of this in terms of like the rampant crime. We don't want to go off on this tangent necessarily, but around the country of gun violence that I'm hearing, we're all hearing murmurings of this. We're all having this trauma and not understanding how to deal with anger and resolving conflict. And I think we've seen some movement forward. I see on television commercials and pop culture references that the stigma that used to be and still is associated with saying, I have depression, I have anxiety, I'm really struggling here, that we're making some inroads to normalizing these experiences. But gosh, in terms of when you said lessons learned, if this isn't an opportunity to just naturally see that this is the time and place to just blow the doors open and do an assessment of where are we with mental health, not necessarily like waiting for people to reach out to us saying, hey, I'm having some problems here, which may be a little bit too late, but being if employee assistance programs and employers and faculty affairs and offices of well-being may be a little bit proactive in helping people to say, are you feeling this? Does this sound, familiar to you? Does this pattern of thinking, or you're not alone? These may be symptoms of whatever. So education, talking about it, normalizing it, not making it hush hush. I think that would be a wonderful way to enhance or fill in some of these gaps. So I think you're right on, Dan. I'm seeing a lot of this residual or full out PTSD that faculty don't know what it is. They're just like, they don't put that name on it, but you can see that's what I can see. I'm not a clinician, but I see, it sounds like that's what it is.
Yes. And I think also to piggyback on that and to echo a colleague who's been a guest on your podcast, Dr. George Everly, I think one of the things I think is important, if I had a sort of a wish, if you will, is universal training on psychological first aid for all health workers. And the reason for that is that, and not to reiterate what Dr. Everly has discussed in any way, but just to sort of amplify on it, psychological first aid is akin to basic CPR for mental health. And it is explicitly designed for people who are not psychologists and not psychiatrists by training. And it includes a variety of facets that are beyond the scope of our discussion necessarily, but include things like recognizing signs and symptoms of psychological distress in colleagues, referring those colleagues, going back to employee assistance programs, to the right resources, active listening, all of these kinds of considerations that are so critical. And frankly, we do not have in the US and internationally a sufficiently large cadre of psychologists or psychiatrists to provide the kinds of scale of services that one can anticipate will be needed for health providers in the short and longer term aftermath of COVID-19 and other disasters. So psychological first aid can be in some way to help, it can be a mode of shoring up those limited resources and to basically allow peer-based intervention among healthcare workers that can be critical as we think about the magnitude of the psychological aftermath of COVID-19 and other events.
Gosh, Dan, this is such important reminder for all of us. And whenever, I talk to people like you, so smart and so like on the pulse of like what's happening at the moment, my mind starts kind of spinning of like, we have to do something on this, about this, we all hands on deck. And I kind of get really amped up about it. And as you were talking, I'm thinking, oh my gosh, we got to pivot to this. This is going to take a lot of resources. We don't have this kind of money. Budgets are tight. We can't even hire people. We can't keep people. What are we going to do? And then I'm thinking, we don't have these things that we think require a lot of investment. Yes, and maybe not so much. And I'm recalling at my gym where I work out, I was filling up my water bottle. I'm like, what is this stupid thing on the wall here? And it was kind of reminded me of some, grade school art project, but all over the walls of the gym, not all over the walls, but strategically around the walls of my gym are good old fashioned pieces of construction paper, 8.5 by 11 construction paper, folded in half the long way. And it's taped to the wall like a flip up question. In the front of the construction paper was a question, and it said, what do chickens work on at the gym? What do chickens work on at the gym? And I'm filling my water bottle and I'm reading this. I'm like, are you kidding me? What is this nonsense? And you flip up the thing and it says their pecs. Get it? And I was like, this is so corny. And yet as I walked away, I was kind of smiling. And then I noticed they're all around the gym. And I thought, well, this is dumb. What's the point of this? But don't you know, as I'm observing, I'm on the treadmill and I'm looking, people are flipping these things up and kind of snickering and they're engaging with a piece of construction paper. And Dan, as you're just now talking, I'm thinking, well, couldn't we straw poll this kind of mental health situation of in the halls of the hospital, in the clinics, in our labs, in our offices? Are you having trouble sleeping lately? Flip up. It may not be caffeine. You may be stressed, or this is not complicated. You don't have to build an app. And I'm thinking, couldn't we have like little stickers or whiteboards or where are you today on the scale of 1 to 10? And people could just walk by and move a magnet, on burnout. I'm at the top of the thermometer. I'm down here. And then you can, as you're walking by, you get a sense of the pulse of where are we on our energy level? How happy are you today? How sad are you today? But these kind of interactive ways of gauging the pulse of a group, it doesn't have to be high tech, right?
Mm-hmm.
Now I'm just making it up.
I think that's exactly right. I think also one of the dual benefits of what you're describing, Kim, is it helps to destigmatize these kinds of considerations. If you have, to your excellent example, placards on the wall and things like that, by definition, you are destigmatizing these things that many people may be, although mental health is thankfully less stigmatized than it used to be, we're still not where we need to be. And that is no less true of provider mental health in terms of feeling stigmatized, having a stigma if they indicate that they need help and so on.
Right.
So I think the sort of a dual tacit benefit of such an approach, and I love the description of what you mentioned here, is to destigmatize.
Right. Carrie, because you said, Dr. Barnett, caring for the caregivers, I think the time is right for this, because this meaning a boost of employee assistance programs, offices of well-being, faculty affairs, because everybody knows frontline workers. I mean, the whole world, we're all about banging pots and pans and thank you, frontline workers, and thank you. So everyone knows that they are fatigued. Everyone knows that they literally put their life on the lines every day and sacrifice. So people know that. Therefore, people would anticipate, well, for crying out loud, you just ran a marathon, have a glass of water and a juice box. I mean, people know you must be tired. So if any time is right, it seems to me this is be the perfect time to say, all right, phew, you done good. Let's bring everybody in for a tune-up. Let's help you out. Let's outfit you with some new resources and a reboost, and let's make sure everything's okay. Let's check all the pieces and parts. How you doing? And as you said, Dan, not a one-off, but let's check in. Are we building? Are we re-energizing?
Exactly. And I think, public health also has a role to play. For example, in terms of mental health surveillance. So, for example, in the aftermath of the September 11, 2001 attacks on the World Trade Center and in the Pentagon and in Pennsylvania, and in other examples, CDC has what's called the Behavioral Risk Factor Surveillance System. And I'm a big proponent of longitudinal mental health surveillance. And that can capture things such as substance misuse, and all other kinds of manifestations that can, frankly, erode, in this case, in the context of our discussion, the capacity of the healthcare workforce to function effectively in the aftermath of, even during and in the aftermath of COVID-19 and other events.
Wow, Dan, brilliant. This is so interesting that you mentioned the BRFSS, because that was my first job up in Michigan, the Michigan Public Health Institute. I was a data analyst for the BRFSS and put out the annual reports for the state of Michigan.
Oh, okay.
And you're right. I completely forgot about that being done on a statewide level. But wow, extracting or replicating that surveillance work in a faculty population. I mean,
yes.
that's what you're saying. That
Exactly.
And I guess I am Matt now. I wish I had now I'm gonna have to reach out to our chief wellness officer, Dr. Lee Doherty Biddison. Is there such a thing? There's got to be something that we do faculty satisfaction. I know a lot of my peers, we do faculty satisfaction surveys. For example, the School of Medicine, every other year we do one. And then we collect the data and then use the next years to kind of come up with strategies and initiatives to address faculty issues. But it's an institution instrument. It's not surveilling mental health. But I'm wondering if well-being and all that burnout in academic medicine, I know there is. Now I'm thinking there's some national effort to look at burnout, but it's not really what you're talking about. It's more, I think it is targeted to burnout versus let's not wait till people are burning out. Let's kind of address this upstream more and do mental health at large. So I think that's really, really smart idea, Dan.
Obviously, every institution is different, and I'm not suggesting that there be a one-size-fits-all approach to this. But I do think the extent that this can be harmonized with federal efforts for like such as BRFSS or other related kinds of surveillance activities can really help to monitor not just the short-term impact and considerations for healthcare workers, but the longer term, because this is going to be a form of silent injury, I hate to say, in terms of mental health, not just acutely, but long-term post-COVID-19. And as we face other threats in real time, I mean, not to be cavalier in terms of, but the idea of walking and chewing gum is, unfortunately, that's the best metaphor I can think of, because it's not like disasters take a break for us, and we have to be able to sort of deal with post-event psychological impacts from one event while also responding to current and future threats. So it's sort of like it's like drinking water out of a fire hose in many ways, but that requires longitudinal support and assessment and surveillance in my view.
To me, the most obvious corollary to what's happening in academic workforce, and you mentioned, when you said heroes and the emotional toll and PTSD, of course, I go to, and I'm sure many of us go to military. And so we have all of our, obviously there's a whole fields and branches of the military that are heroes, literally sacrificing their lives. And so the ones who come back, what can we learn about, as you said, intersections? And I like that picture of not these parallel tracks, but how everything intersects. Anything you can glean? I know I'm kind of throwing, this kind of curveball to you, but what kind of nuggets can we take from that institution of defense, and how we can maybe parlay some of that treatment or resourcing to help our academic career, faculty, clinician investigators be resilient, but not, I don't want to put it on them, because, we always kind of struggle and walk this fine line of saying, just eat better and take yoga and meditate and you'll be fine, coupled with the institution's commitment to, the person, the soldier, the Marine can do whatever she or he can do individually. But if you're in an environment that's not supporting your health and your well-being and your wellness, all's for naught. So can you think of anything that we can learn from that, part of life?
It's a wonderful question, Kim. And I'm a big believer in learning from different institutional cohorts in terms of identifying insights. Now, with that, there is a caveat. With military, there is a compulsory aspect of this, which is not true in the civilian sector. So I say that with a cordial caveat. Having said that, some of the greatest innovations in terms of mental health and other psychosocial aspects come from the military. And I think to the extent that we can adapt and apply insights, current and future, from military-based research toward the civilian sector, a specific focus on the healthcare civilian sector, healthcare provider civilian sector, I think that's all the better. And by the way, I think it's also vice versa. I think that the military can learn from civilian insights too.
Yeah.
Which may seem counterintuitive because, why, since the military, it seems like there's a sort of a resilience that's baked in. Well, actually, there has been, as you may have likely seen, resistance among many military personnel to get COVID vaccinated. And so it is not sort of that military cannot benefit from bidirectional insights from the civilian sector as well.
Yeah, that's another good point. I tend to always, I think many of us do, romanticize the grass is greener. That industry, they really know what's going on here. If we would just follow corporate America, if we in faculty development could just do training like Amazon does, they know everything I want and need and get it to me in 2 minutes. Why can't all y'all do it? So right. I tend to think, well, the VA Health Services Research and Development Field Program, which I worked as in my postdoc at University of Michigan, the Veterans Administration has a great, reputation. And I feel like, well, they must know the answers, and they're probably thinking, you idiot, of course, we've been doing this for, hundreds of years. It's about time. But then again, somebody could say, no, we're all, like you're saying, you're pointing out, Dan, that every industry has its strengths, and looking over the fence saying, oh, they must have it all figured out. They're probably looking at us going, wow, they got it figured out. So you're right. I do appreciate thinking about things in a different culture, a different context. I love learning from other fields and how they apply principles and what they do. And seeing if we can all pick, cherry pick the best nuggets and figure this out, knowing that there's no aha answer. I know that. I mean, I'm not that naive.
But you're exactly right. And just one related note, I think that's really critical, and it's another aspirational item from me from COVID-19. The concept of what's called an after-action report, where you identify what went well, what did not go well. Historically, in disasters, focuses, or not, I don't want to say writ large completely, but historically has primarily focused on procedures and protocols and things like that. And one of the things that I hope emerges from COVID-19 is that after-action reports include psychosocial lessons learned, not just operational lessons learned, not just throughput considerations for clinics, not just how do we manage surge capacity from a sort of a mechanical sense. Those are critical issues, but I think we need to also include the psychosocial insights as part of after-action reporting. And I think COVID-19 has really highlighted the critical relevance of the psychosocial element for identifying lessons learned for continuous quality improvement in health services.
All right, Dan, can you leave us with maybe one, two, or more, as individual human beings listening to this episode right now, psychosocial awareness and sensitivity? What can we, one person, do today to change this, to improve this meaning the psychosocial climate, culture, awareness? What's one thing we can all do? At least one. You got, maybe, I don't know.
Sure.
If you have a list.
Absolutely. No. One is to take a psychological first aid training.
Psychological first aid training.
And there are resources out there that I think it speaks to the earlier comment. I truly believe that everyone in healthcare and frontline response systems, it's just a personal view, but there's evidence behind it, needs to and can benefit from getting trained in psychological first aid, because we need that kind of bolstering of our very limited mental health system in terms of our resources. So that would be the first item.
Got it. And can I hold you there? Is it just kind of broad overview, just going to give us a big quick picture? Is it like ABC's airway, breathing, circulation? Because I am hearkening back to my CPR training. Is it something like you could literally take a class and it's learning the 1, 2, 3s, the ABCs, the blah, blah, blah? Is there some kind of highlights you can give us? Like, what would I learn at psychological first aid training course?
Right. So there are various versions of it. And there's actually a Johns Hopkins, what's called the RAPID, R-A-P-I-D, which I will not belabor the acronym, but there's a Johns Hopkins, it's called RAPID version of psychological first aid. There are other variations of psychological first aid, but the ideas behind these principles include everything from active listening to being able to identify signs and symptoms that may be beyond one's ability to address through active listening itself, and may require referral to someone with more expertise. But the nice thing about the psychological first aid is it can serve sort of as a bulwark against the perhaps overwhelming of the limited public or mental health, formal trained mental health service provider system that we have. So that would be one aspect. Another aspect of psychological first aid relates to self-care. And I think we need to, just to your excellent question, Kim, we need to be more rigorously focused on tools and approaches that are peer-reviewed, and these things are, on best practices for self-care for healthcare providers. In disasters, historically, what do we have? We have donuts and coffee. So caffeine and sugar. And so while that may seem, pejorative, and I don't mean to make it sound that way, those are the two worst things that one can have. in one's system in terms of being able to function effectively. So we need to think about nutrition and rest and all of those kinds of considerations in the field of disaster research and even physiological research and mental health research, and bring those to bear to create an improved, a very practical approach to self-care for healthcare providers and other frontline workers.
Love it. Thank you. Thank you. Thank you. I cut you off when you were saying another thing, in addition to psychological first aid training, something else we can all do.
Yeah, no. So I think also self-awareness of mental health, symptoms and signs that one may be experiencing. I think often there is a feeling that that's a sign of weakness to recognize it, or we just plow ahead. But I think along with psychological first aid training, a greater self-awareness of signs and symptoms in oneself that may portend problems that could snowball. And so I think learning about signs and symptoms of burnout, learning about signs and symptoms of compassion fatigue, all these things that we've talked about should be, frankly, part of, in my view, healthcare system-wide training curriculum. This is, as they say, a teachable moment as we think about COVID-19 and what we are learning from in real time. And I think, the time is now to really think actively about how we do trainings to help healthcare workers recognize what burnout looks like, recognize what PTSD looks like, so that they can be more self-aware. And to your earlier point, the third thing I would say is to destigmatize all of this through the kinds of excellent example that you gave of having, visual placards and things like that. We at Hopkins Hospital, the amazing work of Peter Pronovost was reflected in, the steps that one would take, for example, for hand washing and for hand hygiene, as I recall having seen it on the walls at Hopkins Hospital. So Hopkins Hospital, among others, has been at the vanguard of that kind of visual display as a way of behavior change or awareness. Yeah. And I think that I'm not exclusively praising Hopkins Hospital. There are many hospitals that do this, but I think that kind of model can and should be replicated in the context we're describing here.
Great, Dan. Oh, I love all this. I'm so excited, and I really want to go out and do stuff and make this happen. And you really inspired me to dig into this and do what I can personally. And I think what I can do is just start incorporating or weaving in this recognition in all the work I do in faculty development. For years now, I've started all my sessions with hey, let's take a pause and celebrate who has given birth to a human, a paper, a grant application. These things are very, babies and grants and papers take a long time to grow. And so who got promoted. So I'd start with celebrations to remember that we honor and appreciate the good things we're doing in struggling and challenging times. But now you're also making me think that we need to think about weaving in the flip side of that. And before a session, maybe these polls that you could do in Zoom and in Qualtrics and on your cell phones, on a scale of 1 to 10, how burned out are you feeling right now? Right. Maybe it's not even on the session we're going to do today, but just before you start a faculty meeting or a lab meeting, it's all anonymous. Where are we? Where are we as a group? And have people go, phew, I'm glad we're lower than we were last week or last month, or, oh my gosh, the pot is boiling. This is important canary coal mine kind of situation. So you're really inspiring me to think of ways that instead of waiting for an office of or a center for or a team of people to, we individually, leader of one, I can do it for myself. All right, Kim, what you're feeling is tense. Why are you feeling so tense? Why are you feeling so, angry? Or then sharing with people, I'm feeling anxious. I'm feeling nervous. I'm feeling sad. And modeling that, but also then what can I do with my groups that doesn't require a huge investment of, again, equipment, supplies, questionnaires, just kind of asking people and listening. I love how you talked about the psychological first aid of active listening. So this is just so great. You got me all amped up.
I'm glad this was helpful. I would just say one other thing. It's a good news piece of comment is that there are some very well-validated burnout scales that can be incorporated. There's a Maslow burnout scale and others. So we don't necessarily even have to reinvent the wheel in terms of assessing these kinds of things.
That's right. Absolutely. Well, Dr. Dan Barnett, see, I knew this would be another good conversation, right? Everybody out there, if you want to reach out to Dan, you can email him at dbarnett, BARNET 4 at jhu.edu. I'll say that again, DBARNET 4 at jhu.edu. Check out his episode number 173. A few months ago. It was super cool. Another great conversation. And Dan, thank you so much again. You really are inspiring. You're so smart. I love learning from you and applying these really important principles to faculty affairs and faculty development. So thank you for the work you're doing. And thank you for being on the podcast.
Well, thanks very much, Kim. I appreciate it. Thank you.
Bye, everybody.
Thanks for tuning in to Faculty Factory Podcast. The mission of the Faculty Factory is to build and support a community of leaders in faculty development who share tools, resources, wisdom, and encouragement in service to our faculty members, schools, and institutions. We encourage you to go to facultyfactory.org to find out more, get in touch with me, ask me any questions. Maybe you want to be interviewed on the podcast. Thanks for tuning in to Faculty Factory Podcast. We'll see you next time. The Faculty Factory podcast and website is sponsored by the Johns Hopkins University School of Medicine Office of Faculty. For more information, visit facultyfactory.org.